Welcome to another video by My Hematology, where we make hematology simple. Today we will be covering the topic of disseminated intravascular coagulation, also known as DIC. So what is DIC? DIC is a complex and often life-threatening disorder in which widespread blood clotting occurs throughout the body. It is a hemostasis disorder and is commonly encountered in a variety of medical, surgical, and obstetric settings. DIC is defined as a widespread activation of coagulation and fibrinolytic pathways as a secondary complication causing generalized hemorrhage and thrombosis. This excessive clotting can lead to consumption of clotting factors and platelets, resulting in a bleeding diathesis. The hallmark of DIC is the activation of both the coagulation and fibrinolytic systems. This activation leads to the formation of microthrombi or small blood clots in the microvasculature. The microthrombi can obstruct blood flow and damage small blood vessels. The consumption of clotting factors and platelets can lead to bleeding, which can manifest as bruises, petechiae, or even major hemorrhage. So what are the causes of DIC? DIC never arises de novo, but rather as a consequence of an underlying pathologic process. The two main conditions that precedes DIC are the release of tissue factor from injured vessels or the release of tissue factor from injured or pathologic tissues. In addition, injury to the endothelium can cause in situ thrombus formation. Sepsis is the most common trigger of DIC among medical or surgical inpatients. Sepsis is a life-threatening condition that occurs when the body's immune system reacts to and overreacts to an infection. Sepsis is a major cause of DIC, as the inflammatory response can trigger the activation of both the coagulation and fibrinolytic systems. The causes of bacterial sepsis includes gram-negative and positive organisms, meningococcus, and pneumococcus. DIC may be initiated by diffuse vascular injury caused by hypoxia, acidosis, and shock, often coexisting in very sick patients. Trauma can cause DIC by releasing tissue factors that activate the coagulation cascade. DIC is a common complication of major trauma such as car accidents, falls, and gunshot wounds. In obstetrical patients, DIC is induced by release of fetal cells or fluid in maternal circulation, for example, in placental abruption, retained placenta of fetus, amniotic fluid embolus, and others. Obstetrical DIC usually resolves promptly with surgical correction of the problem. In addition, procoagulant material can be released in certain malignant conditions like mucin-secreting adenocarcinomas and acute promyelocytic leukemia. In other medical conditions like severe burns can also cause DIC. As you can see, there are various triggers of DIC. What is the pathophysiology of DIC? The pathophysiology of DIC is complex and not fully understood. However, it is believed that DIC is caused by the activation of both the coagulation and fibrinolytic systems. The key event underlying DIC is increased tissue factor activity. This can come from its release into the circulation from damaged tissues present on tumor cells or from upregulation of tissue factor on circulating monocytes or endothelial cells in response to pro-inflammatory cytokines like tumor necrosis factor and endotoxin. These are in sufficient amounts to activate blood coagulation systematically, whereby overwhelming normal hemostatic regulatory mechanisms. As a result, the coagulation cascade is ignited to such a degree that coagulation factors are consumed along with platelets. In DIC, microangiopathy is caused by the formation of microthrombi in the microvasculature. The microthrombi can cause obstruction of blood flow and damage the vessel walls. This can lead to a number of complications such as organ dysfunction, bleeding, and death. This process is accompanied by secondary fibrinolysis due to activation of plasmin, which may digest any fibrin that is formed. Depending on the balance of prothrombotic and antithrombotic derangements, tissues from affected patients may show widespread deposition of fibrin and platelets throughout the microcirculation, accompanied by tissue damage, hemorrhage, or a combination of both. The activation of the fibrinolytic system leads to the breakdown of fibrin. This can help to prevent the growth of microthrombi. However, the excessive activation of fibrinolysis can lead to the degradation of fibrinogen and other clotting factors, which can exacerbate the bleeding diathesis. So, the key events in the pathophysiologic DIC includes initiation. The coagulation cascade is activated by a variety of triggers such as tissue factor, thrombin, and activated protein C. Then is propagation. The activated coagulation factors generate thrombin, and the thrombin converts fibrinogen into fibrin. Thirdly comes the clot formation. Fibrin forms a mesh that traps the red blood cells, platelets, and other blood cells, and this forms blood clots or microthrombi. Next is the fibrinolysis. The fibrinolytic system is activated. Plasmin is generated from plasminogen and plasmin breaks down the fibrin. Fifth, we have consumption and overconsumption of clotting factors and platelets in the process of clot formation. This can lead to a deficiency of clotting factors and platelets. And lastly, there's the bleeding. The deficiency of the clotting factors and platelets can lead to bleeding. So, what are the clinical features that are associated with DIC? The clinical features of DIC can vary depending on the severity of the condition. However, the features can be loosely categorized according to the key mechanisms involved in the pathophysiology of DIC. Thrombocytopenia due to excessive consumption of platelets in DIC leads to bleeding that can manifest as bruises, petechiae or small red spots on the skin, epistaxis or nosebleeds. Coagulation or clot formation can manifest as deep vein thrombosis, pulmonary embolism, stroke, myocardial infarction, or heart attack. And fibrinolysis can lead to microvascular dysfunction, which can result in a variety of symptoms such as organ dysfunction, shock, and death. Fibrinolysis can also cause hemorrhage, hematuria, and anemia. What are the laboratory investigations available for DIC? The laboratory investigation for DIC are aimed at assessing the activation of both the coagulation and the fibrinolytic systems. Patients with DIC have both thrombocytopenia and global abnormalities in the coagulation profile. There will be high levels of fibrin degradation products such as D-dimer in the serum and the urine. And the peripheral blood smear will show hemolytic anemia. The red cells will have prominent fragmentation or schistocytes. In addition to these laboratory investigations, Other tests may be ordered to assess the underlying cause of DIC. For example, a blood culture may be ordered to rule out sepsis. The interpretation of laboratory investigations for DIC can be complex. A combination of abnormal test results is typical needed to make a diagnosis of DIC. In some cases, a scoring system may be used to assess the likelihood of DIC. So, how then is DIC treated and managed? The treatment and management of DIC are aimed at addressing the underlying cause and preventing further clotting and bleeding. The specific treatment approach will vary depending on the severity of the condition and the underlying cause. So, first and foremost, we would treat the underlying cause, which is the most important step in the treatment of DIC. This may involve treating an infection, removing a tumor, or controlling the bleeding. The treatment of bleeding patients is different from thrombotic patients. Bleeding patients can be given supportive therapy with fresh frozen plasma and platelet concentrates as indicated in patients with dangerous or extensive bleeding. If clotting factors or platelets are consumed, they may need to be replaced. This can be done with transfusions of fresh frozen plasma, cryoprecipitates, or platelets. On the other hand, the use of heparin or antiplatelet drugs to inhibit the coagulation process is considered in those with thrombotic problems. Before we wrap up, let's go through the key points of DIC again. The signs and symptoms commonly seen in DIC includes bleeding, thrombosis, tissue damage, and necrosis due to the thrombosis. And DIC can be caused by a myriad of factors, including hypersensitivity reactions, infections, neoplasms, obstetric complications, vascular disorders, widespread tissue injuries, and others. And how do we investigate laboratory investigations? There will be microangiopathic hemolytic anemia and thrombocytopenia that can be seen in the full blood count. There will be increase of APTT, PT, TT bleeding time, FDP, as well as the D-dimer, but a decrease in the platelet count and the fibrinogen. And how do we treat DIC? First, we have to treat the underlying cause. And then for bleeding patients, we give supportive therapy with fresh frozen plasma, platelet concentrates, and cryoprecipitates. While in thrombotic patients, anticoagulant therapy such as heparin may be used. Protein C concentrate and antithrombin can also be used in selected patients. So there we have on DIC. If you like this video, click like and subscribe for more videos, and thank you for watching.